All right, now we're going to switch gears and talk about biomarkers versus functional markers in terms of diagnosis of AKI. So first, I wanted to make sure it's clear what's the difference between the two, right? Because you guys probably heard of these terms before, but sometimes it's a little bit confusing. And functional markers basically are diagnostic tests that will help you to estimate kidney function, right? So you can see here we have glomerular filtration rate that in theory and in practice you can measure, but it's a little bit cumbersome, and we'll talk about it in a few slides. But this is probably the gold standard way to determine the kidney function. There are also biochemical surrogates of GFR, right? So this is something you're very familiar with: creatinine, BUN, SDMA. So these are biochemical substances that you can measure in the blood, and based on their levels, estimate the GFR in your patients. That we call them surrogates of GFR. So it's not a direct way to measure GFR; it's kind of indirect way, and it's very convenient and cheap and non-invasive. However, it's not as accurate as a direct way to measure GFR. And then you can use urine output as a functional marker, right? So it's not perfect, and we'll talk about that. There are a lot of limitations, but in theory, it is also kind of a variation of functional marker. And then there are biomarkers. So these are things that you can measure or test that will give you an idea about structural damage of the kidney tissue, but it doesn't tell you about the function, right? So the function could be preserved, but the biomarkers could be abnormal. So they're going to be positive. And there are a lot of different biomarkers you can read about, and there are a lot of studies. A lot of them are in the research setting, so you may not have access to them, but these are biomarkers you can actually get access to on a commercial basis. And potentially some of them have even point of care snap testing that you could do right now if you purchase them from different companies. Things like NGAL, KIM1, urine GGT, urine alkaline phosphatase, urine cystatin B, and serum amyloid A. So we'll touch on some of them. So I think this graph is really helpful to just conceptualize the difference between the two and why biomarkers become more popular and why people want to research them and potentially introduce them to clinical practice. So if you look at this graph here, you see y-axis, x-axis. On the y-axis, you see different levels of concentrations of different functional or biomarkers and the AKI threshold. So once they reach this level, that means the patient has AKI. On the x-axis, you see just timeline from baseline to 48 hours out. And then let's focus on two things. So one of them will be creatinine, which is the most common functional marker we use in practice. So that's going to be our purple solid line right here. And let's focus on NGAL, which is relatively popular biomarker, and it's going to be a red solid line right here, right? So let's say you have a completely healthy patient that was anesthetized for surgery, and surgery and anesthesia is a known risk factor for AKI. Something happened during the surgery, whether it's ischemia or inflammatory surgical injury, and this patient, you know, got exposed to the insult and start developing AKI due to that. And if we use creatinine as a way to diagnose AKI in this patient, let's follow this purple solid line. So it's still way within normal limits up to 48 hours. And only 48 hours later, it reaches the point of AKI threshold, let's say increase of creatinine by 0.3 or 26 micromoles per liter. So that means this patient developed AKI during surgery, but you had no idea about it up until 48 hours later. So the biggest takeaway from this is that creatinine is a relatively delayed marker of AKI. So it may take you 2, sometimes a little bit longer days before you diagnose AKI solely based on creatinine. Now, let's look at NGAL. So NGAL shot up really quick. It went up to AKI threshold within minutes to hours, even during the surgery, right? So you already know that the patient developed this structural damage, tubular damage to the kidneys. within very, very short period of time, even before you finish the surgery, if you tested NGAL concentration. And then it peaked at 3 to 6 hours. So again, it's much faster than creatinine concentration, right? So this is the main benefit of using biomarkers in a setting of acute kidney injury. And that's because they give you this information almost in real time, very fast, but there are obviously some limitations that we're going to talk about. So next, I want to talk about the relationship between creatinine versus GFR. And I mentioned that creatinine is a biochemical surrogate of GFR. So the reason we like measuring creatinine because we want to know what the kidney function is. So basically what GFR is, right? This relationship exists on this exponential curve. Okay. So on the y-axis, you see plasma creatinine concentration. Here it's in milligram per deciliter, but I also put micromoles per liter here for certain points that we're going to discuss. And then on the x-axis, you see GFR in mils per minute. So let's say you have a patient that has completely normal kidney function. GFR is at 120 mils per minute, which corresponds to creatinine of 1 milligram per deciliter or 88 micromoles per liter, which is well within normal limits. So this patient has normal GFR and normal creatinine. Now, something happened to this patient and creatinine went up to 2 milligram per deciliter or 177 micromoles per liter. So it went up by 1 milligram per deciliter, about 88 micromoles per liter. And this corresponds to a drop in GFR from 120 to 60 mils per minute. So this relatively small change in creatinine led to decrease in GFR by half. So the main takeaway from this kind of part of the conversation is that if your patient exists on this flat portion of the curve, exponential curve, relatively small changes in creatinine are associated with very big changes in GFR. That's why we care about 0.3 milligram per deciliter, 26 micromoles per liter, because that change is a significant drop in GFR, especially when they have normal creatinine to start with. Now let's take another patient. So this patient, let's say, has established CKD. So their baseline creatinine is 3 milligram per deciliter, about 265 micromoles per liter. Now let's say this patient had increasing creatinine by exactly the same value, absolute value of 1 milligram per deciliter or 88 micromoles per liter. So it went up from 265 to 354 or from 3 to 4. So similar, the overall change is similar to the previous patient. But if you look at GFR in this patient, it dropped only from 40 to 30. So exactly the same absolute change in creatinine is associated with relatively small change in GFR. So when your patient exists on this vertical part of the exponential curve, same changes of creatinine signify relatively smaller changes in GFR as opposed to patients with completely normal creatinine. So I think it's super helpful, especially when you have a patient, with azotemia in 5, 6, or like full 500 micromoles per liter, and they fluctuate their creatinine. Remember that this change in creatinine actually is not that significant in terms of GFR, as opposed to a patient with completely normal creatinine.